Good day, future medtechs and future doctors. This is Dr. Francis Ian Salaver, and I will be talking about Introduction to Immunology. Every time that the immune system is discussed in classes and students are asked to discuss about it, most of the students would say that the immune system is the function of the white blood cells because white blood cells are known to protect us from invading microorganisms. But there is more to the immune system than just the functions of our different white blood cells. Why? Because the different immune responses that we have in our body are not only provided by white blood cells, they can also be provided by tissues, by organs, and by the different soluble substances that we have in our serum. All of these are components of what we call immune system, and the study of immune system is immunology. The immune system is composed of cells, tissues, organs, and even soluble substances that can generate immune responses and provide us what we call the state of immunity. When you say immunity, this is the ability of our body to resist an infection. At this point, we will be discussing the individual components of our immune system. Let us first start with the cells. Good example is our white blood cell. As you can see in this picture, this white blood cell will kill foreign materials such as bacteria, yeast cells, and etc. And the phagocytosis will lead to the killing of such foreign material. Another component of the immune system is the tissue. And the best example I can give you guys is the connective tissue. And we will discuss this one on the next slide. Pointed by the red arrow is the epidermis. The epidermis of the skin is composed of several layers of cells which can prevent the entry of microorganisms into our body. Should there be an injury, and that injury led to the introduction of bacteria into the underlying connective tissue, the connective tissue will use some of its components such as hyaluronic acid and other ground substances to not allow the bacteria to spread to other areas in our body. So therefore, this one will only prove to us that tissues in the body can also provide immunity. And the main purpose of not allowing the microorganisms to spread to other areas in the body is to contain them and wait for the white blood cells to reach the site of infection, and these white blood cells now will kill these invading microorganisms. The third component of the immune system is the organ, and the best example I can give you is our skin. The skin is lined by stratified squamous keratinized epithelium, and it provides a good barrier against the entry of microorganisms into our body. So I hope at this point you have already realized that the immune system is not just the function of our white blood cells. The last but not the least among the components of the immune system are the soluble substances. And the best example I can give you is our antibody. So the point is, all of the components of the immune system will provide us the state of what we call as immunity. And immunity is the ability of the body to resist or fight off an infection. If the body cannot resist the infection, then you call that as the state of susceptibility. If you can resist the infection, you are said to be immune. If you can't, then you are described to be susceptible. Let us now go with the functions of the immune system. Number one, the most commonly known, defense. Defense would mean that the immune system will provide protection against invading microorganisms. Every time that the microorganism will try to enter the body, the immune system will try to eliminate it, and that's what we call as defense. It's not okay to think that the immune system is just there to defend us from the entry of microorganisms, because it's like saying that you only need to turn on your immune system if there is that invasion of microorganism, and you will put it off if you feel okay or normal or healthy. I want everybody to understand that the immune system is working every second of the day because there is more to the immune system than just providing us defense. So I want you to take a look at the cells in the picture. You have here a normal cell, and the cell beside it has undergone malignant transformation. I want you to understand at this point that the cancer cells did not invade the body. They developed inside our body. So, if they will be attacked by the components of the immune system, you should not call it as defense because there is no invasion of microorganisms to start with. So I want you to take a look at the natural killer cells and the T cytotoxic T cells. Do you know what they are doing in the body? They check every cell in the body, and they would check if these cells would have any changes in their antigenicity. Because if they have changes in their antigenicity or appearance or morphology, these cells will think that the cell in front of them has undergone malignant transformation. And this natural killer and T cytotoxic cells will initiate an immune response that would end up to the lysis of the malignant cell or cancer cell. And this is now the second function of our immune system. And we call this one as surveillance. So the first function is defense, and the second function is surveillance. When you say surveillance, the immune cells or other components of the immune system will check all the cells in the body and check whether they have undergone malignant transformation. If they do, they will be subjected to apoptosis or lysis. The third function of our immune system is to remove cellular debris, and they can also participate in tissue repair. So for you to understand this one, I want you to take a look at this photo. Cells in the body, especially the old ones and the damaged ones, undergo apoptosis if it is part of the normal physiologic process, meaning the cell has to die because there's something wrong with the cell and it will commit itself to programmed cell death. While some cells die because they are subjected to injury, and you call that one as necrosis. But the point is, both apoptosis and necrosis will lead to the production of cellular debris. And you cannot afford to have this cellular debris floating in the blood because it might obstruct smaller capillaries. So, there must be a mean on how to remove them. And what will remove them are our phagocytes. That's why the immune system can also function to remove cellular debris. On the next slide, I will be explaining to you how the immune system will also participate in tissue repair. Shown in the schematic diagram is an injured site of the skin. As you can see, the first white blood cell that will reach the site of infection is the neutrophil. Also shown in the picture is a macrophage. Macrophage is one of our immune cells. It is derived from the monocytes in our blood. And take a look at the action of the macrophage in the picture. Can you appreciate that the macrophage is releasing cytokines? Do you know that some of these cytokines will activate the fibroblasts in the connective tissue of the skin? As you have learned from your histology, fibroblasts will multiply in response to injury, and the fibroblasts will produce collagen, and collagen will be used for tissue repair. So therefore, we can also conclude that the immune system is also involved in tissue repair. There are several ways on how to classify immunity. One of which is to classify immunity or immune responses as two: innate or nonspecific, or adaptive or specific. Please take note that when you classify immune responses to be nonspecific, it means that they will provide protection against a wide variety of microorganisms. They will not choose what to protect you from. But when you say that the immune response is specific, they will only attack a particular type of microorganism or antigen. For you to understand the discussions on innate immunity and adaptive immunity in the succeeding slides, I will first give you examples. Now, when you say innate immunity, aside from protecting us from a wide variety of microorganisms, this type of immune responses are already present upon birth. And a good example I can give you is our skin. The skin protects us from different microorganisms. It will basically not allow any microorganism to enter our body. It tends not to choose what to protect us from. And it has been protecting us from the time that we are still inside the uterus of our mother up to the time that we were born and until today. When you say adaptive immunity, you need to be exposed first to the antigen or to the microorganism before you will develop the immune response. Meaning these immune responses are not present upon birth. And a good example I can give you is our antibodies. You know very well that you need to be exposed first to the offending agent or the microorganism before you will produce antibodies. So, can I ask someone from the class already have antibodies to chickenpox when he or she was born? Diba? You need to develop chickenpox first before you will develop the antibodies against the chickenpox or varicella virus. Let us first start with innate or non-specific immunity. By the way, this type of immunity is also referred to as natural immunity. Why innate? Why natural? Because as mentioned a while ago, they are already present upon birth. Innate, natural of you. And this type of immunity is described or called as non-specific because it can protect us against a wide variety of microorganisms. The problem with innate or non-specific immunity, whatever amount of immune response that it will provide you today will be the amount of immune response that it will provide you tomorrow. Diba? Every time that you are hurt, you're supposed to learn from the experience and you're supposed to know how to handle it the next time that you will encounter it or feel it. But in the case of innate or non-specific immunity, it seems that you're not learning. Another problem with innate or non-specific immunity is that it cannot distinguish what is self from non-self. That's why if these immune responses are activated, they might also cause tissue destruction. On the other hand, acquired, adaptive, or specific immunity is only developed after a previous exposure. That's the reason why it's called acquired, because you don't have it initially. You only develop it after you encounter the antigen. It's also called adaptive because it's one of our body's way to adapt to the living world. And the reason why this type of immunity or immune responses are referred to as specific immunity because they will only particularly target a specific antigen. What is good about acquired, adaptive, specific immunity is that the more that you are exposed to the antigen that caused you to develop the immune responses, the higher the magnitude of the immune response that you will produce. Meaning, if you had chickenpox before, you will develop antibodies against the chickenpox virus or the varicella virus. And if you will encounter someone with chickenpox in the future, what will happen is your body will generate more or higher amount of antibodies. The only problem with adaptive immunity is that it can only protect you to the microorganism that you were exposed to, I mean. So, let's say for example, I had chickenpox before, so I already have antibodies to chickenpox now. So if I will encounter someone with chickenpox, I will produce higher amount of antibodies against the virus, right? But if I will encounter someone with measles, and if I did not develop measles in the past, what will happen is my antibodies to chickenpox will not be able to protect me from the measles virus. Innate immunity will not choose what to protect you from, but adaptive immunity can only protect you to the organism that you are exposed to in the past. But the good thing about adaptive immunity, again, the more that you will be exposed, the higher the amount of immune responses generated. Why do you think the adaptive immunity can generate a higher magnitude of response upon re-exposure? Because the cells involved in adaptive or acquired immunity are T cells and B cells. And these cells are known to generate memory cells. So they will not anymore forget the organism that caused you to become sick. That every time that you will encounter the same antigen, they will automatically generate an immune response. So from now on, if you will be asked to classify immune responses as to innate or adaptive, all you have to remember is adaptive immune responses have something to do with the functions of our T cells and B cells. If the immune response has nothing to do with T cell and B cell, automatically that immune response is classified under innate or non-specific immunity. So at this point, I want to assess the extent of your understanding of the differences between innate and adaptive immunity. So let's start. Which among them is also referred to as natural immunity? The answer is innate immunity. Which among them is also known as specific immunity because it will only attack a particular antigen? Yeah, the answer is adaptive. Which among them does not increase the magnitude of immune response upon re-exposure? Does not increase the magnitude of immune response. The answer is innate immunity. Which among them is already present upon birth and you don't have to be exposed to the microorganism before you will develop this set of immune responses? Yeah, it's the innate immunity. Next, which among them is also known as the acquired immunity? Adaptive, you're correct. Which among them is also called as the non-specific immunity? When you say non-specific, it will provide immune responses against a wide variety or list of microorganisms. It's innate immunity. The next statement or item is a little tricky and I want you to think now before you will choose your answer. Which among them will provide the fastest and immediate response? So I'll give you 10 seconds to think. Most of you would think that antibodies are good in what they are doing. They can automatically kill microorganisms upon recognition and binding to them, right? So some of you might have answered adaptive immunity because we always think that antibodies are really the core of the immune responses. But the answer to this particular item is innate immunity. Why? They can automatically generate the immune response because you already have them since the day that you were born. Antibodies are usually produced later in the course of the disease. That's why they cannot provide you the fastest and immediate immune response. Last, ang kagandahan at kagwapuhan ng third year BSMLS students ng San Pedro College. Yeah, it's innate. You already have it when you were born. Let's have a second set of quiz. This time, you have to classify immune responses as to innate or adaptive immunity. Please recall that innate immune responses are already present upon birth and they will not choose what to protect you from. But when you say adaptive immune responses, these are always linked to the function of T cells and B cells. So let's start. First, the hydrochloric acid in our stomach causing the bacteria present in the food that we have ingested to die. Since hydrochloric acid will basically kill any type of bacteria, and our stomachs can already produce hydrochloric acid since the day we were born, so therefore, this immune response is classified as innate immunity. And there's no mention in the statement that there are T cells and B cells involved, right? Next, do you know that we have this particular enzyme in our tears and saliva that can target the cell wall of bacteria? So, this type of immune response falls under what? Innate immunity. Because lysozyme in tears and saliva will target any bacteria as long as their cell walls are susceptible to its action. So every time you will kiss your future husband and wife, you have to tell them, aside from expressing my love, I'm also sharing to you my lysozyme for additional protection. Next, we have fever. How will you classify fever now? Will it be classified under innate immune response or adaptive immune response? I'll give you a clue. You will develop fever regardless of what organism is causing you to become sick. You develop fever against viral infection. You develop fever against bacterial infection. And some parasitic infections will also manifest with fever. So, therefore, fever is classified under innate immune response. Next, how about antibodies? Do you have them when you were born? Or you only developed them after you were exposed to the antigen or microorganism? The correct answer is antibodies fall under adaptive immunity, and antibodies are produced by plasma cells. Plasma cells are the differentiated or activated form of B cells. So as you can see, any immune response that is linked to the function of T cells and B cells will be classified under adaptive immunity. Next set, number 1, virally infected cell, meaning there's a virus inside the cell and the virus is multiplying or replicating, and that virally infected cell is destroyed or killed by T cytotoxic T cell as shown in the picture. The answer is adaptive because there's involvement of T cytotoxic cell. Okay? Next, what if the virally infected cell is destroyed by natural killer cell? This one is classified under innate immunity. So from this point on, I want you to remember specific immune response against viruses is produced or generated by T cytotoxic cell because T falls under adaptive immunity. Non-specific or innate immune responses against viruses are mediated by natural killer cells. So I hope you will not forget that from now on. The second to the last question or statement, we have phagocytosis. Are our phagocytes choosing what bacterium to ingest or not? Or as long as they will see any foreign microorganism, they will try to eat them? Phagocytosis falls under innate immunity. So just try to imagine, if our phagocytes will only choose what to eat, most likely we will have infections every day. Next, the last item, plasma cells. Since they are the activated form of B cells, therefore, they are classified under adaptive immunity. Adaptive acquired or specific immunity is particularly linked to the function of T cells and B cells. if the immune response is generated by B cell, you classify that particular adaptive or specific immunity as humoral immunity. Humor was derived from the Greek word which means substance. B cells are known to differentiate to plasma cells, and plasma cells are known to produce antibodies, and the substance being referred to in this case is the antibody. So take a look at the picture of this B cell. This B cell will form the plasma cell. So that's the B cell, and this B cell will differentiate to form the plasma cell, and the plasma cell formed will produce antibodies, substance, soluble substance, and these antibodies now will attack the offending microorganism. So when you say humoral immunity, the B cell will not directly confront the antigen. The B cell will just throw antibodies at them. The other cell involved in acquired or specific immunity is the T cell, and the type of immune responses it can provide us is classified as cellular immunity, meaning the T cell will interact with the antigen or the virally infected cell, and the T cell will cause them to undergo lysis. So take a look at the green colored T cells in the picture and look at how they are interacting with the red colored cancer cells, and the interaction caused the cancer cells to undergo lysis. So since there is cell-to-cell interaction in the immune response, you will classify this one as cellular immunity. Active and passive immunity are further classified as natural or artificial. Natural active immunity would mean, okay, so from now on, I want you to imagine, for you to easily understand this topic, when you say natural, you acquired the infection through the usual mode of transmission. So let's say, for example, you developed malaria because you were bitten by the female Anopheles mosquito. You developed measles because you were exposed to the droplets of someone with measles. So that's what we mean by natural type of immunity. So when you combine the terms natural and active immunity, it would only mean that you naturally acquire the infection and you produce the immune response against that particular offending agent or microorganism. But when you say artificial, it would mean that the antigen or the microorganism or the weakened microorganism is introduced into your body through another means of mode of transmission. So what do you mean by that? Let's say, for example, measles supposed to be acquired through exposure to respiratory droplets, but you can also introduce the antigen of the measles virus through an injection or through vaccination. So if you introduce the organism or the antigen through vaccination or through means of a syringe, then you're inducing the immunity the artificial way. So when you develop the immune response against a component of the vaccine, then you refer to it as artificial active immunity. Recovering from measles is natural active. Developing immune response to measles after you receive the vaccine to measles is referred to as artificial active immunity. But the common thing between the two is you are playing the active role of producing the immune response. It's just that you were exposed in different ways, no, in natural and artificial type of immunities. To make you understand the difference between natural active and artificial active immunity, so I want you to take a look at the case of COVID-19. COVID-19 is naturally acquired through respiratory droplets. So if someone will develop COVID-19 because of this usual mode of transmission, and if that person will recover and will develop immune response, the immune response is classified as natural active immunity because the COVID-19 infection was acquired naturally and the person played the active role in producing the immune response. But if a person will be given vaccine to COVID-19, so this is not the usual way of acquiring COVID-19 infection, no? So the person is receiving an artificial type of immunity. And if that person will produce immune response against the component of the vaccine, then this type of immunity is called as artificial active immunity. In both cases, the person involved played the active role in producing the immune response. Passive immunity can also be classified as natural passive or artificial passive. So as what I want you to remember is in passive immunity, the main person is not playing the active role in producing the immune response. For you to understand what you mean by natural passive, I'll give you an example. The transplacental transfer of antibodies from the maternal circulation to the fetal circulation. So IgGs of the mother will cross the placenta and will transfer to the blood of the developing fetus. In the case of the fetus, the antibodies were not produced by his or her own immune system. So you will classify that one as passive immunity. And I want you to understand that the means of acquiring the IgGs followed or is because of a natural mean. And that is what? Transplacental transfer of antibody. So therefore, this form of immunity or immune response is classified as natural passive. Another example so that you will be able to understand or grasp the idea of natural passive immunity, breastfeeding. Do you know that breast milk is rich in secretory IgA? Now, that's the antibody present in the breast milk. So if the infant will feed on the breast milk of the mother, the infant will be getting the secretory IgA in the breast milk of his or her mother. So since the IgAs were not produced by the infant, then you will classify this one as passive immunity. And since the transfer of IgA followed a natural mean, no, it's really natural for the breast milk to contain IgA, then you will classify this one as natural passive immunity. When you say artificial passive immunity, there's also transfer of immune response or antibodies from one person to the other. But this time, it doesn't involve the placenta and the antibodies are not present in the breast milk. The transfer is not a form of natural means. A good example I can give you is, let's say for example, a person or a donor who had already recovered from COVID-19 will donate his plasma or antibodies to someone with severe COVID. So those plasma or antibodies will be introduced into the IV line or into the veins of the patient with severe COVID. So there's also involvement of injections or needles, just like in the case of artificial active immunity. Since the patient with the severe COVID does not own the antibodies, you will refer to it as what? Passive immunity. And since it was just introduced into the body of the patient with severe COVID and does not follow the natural means of the transfer of antibodies, you will now refer to it as artificial type of immunity. And that example is classified as artificial passive immunity. So at this point, we will try to assess whether you can already classify immune responses as natural active, natural passive, artificial active, or artificial passive. Okay, question number 1. Recovery from German measles and production of immune response against the German measles virus or the rubella virus. This is an example of natural active immunity because you got the infection through natural means and you develop the immune response. How about breastfeeding, which can provide the infant secretory IgA or IgA2? This is an example of natural passive immunity because the baby does not own the antibodies. They were from the mother and the transfer is through a natural mean, and that is breastfeeding. Very good. Next, transplacental transfer of antibodies from the mother to the developing fetus. This is also an example of natural passive immunity. What I want you to learn from this slide is the antibody that we can get from the breast milk is secretory IgA. The antibody that can cross the placenta is IgG. Let's have a case. A guy had a motorcycle accident. Fortunately, he did not have any fractures. He only sustained abrasions and lacerations. The lacerations were sutured. One of the things that the physician ordered in the emergency room is to administer tetanus toxoid to the right deltoid area of the patient. Please take note, tetanus toxoid contains inactive tetanus toxin. And the main purpose of introducing the inactive form of the toxin is for our bodies to produce antibodies against the tetanus. Because wounds such as abrasions and lacerations can increase the chance for Clostridium tetani infection, which will later lead to tetanus, which can be life-threatening. So, administration of tetanus toxoid to the patient, you can see the syringe, that's the clue, is an example of what type of immunity? Natural active, natural passive, artificial active, or artificial passive? 5 seconds to think. Correct answer is artificial active immunity because the antigen was not acquired through natural means. It was introduced into the body through the syringe. And this is vaccination, right? And the person who received the tetanus toxoid will later develop the antibodies. So that's active form of immunity. So this is artificial active immunity. Do you know that the physician will also order the administration of tetanus immunoglobulin on the left deltoid area of the patient? Tetanus immunoglobulin is named such because this type of vaccine contains commercially prepared antibodies. And these antibodies were produced in the laboratory. This administration of tetanus immunoglobulin is an example of what? Natural active, natural passive, artificial active, or artificial passive? 5 seconds to think. Correct answer, this is artificial passive because what you introduce into the patient are prepared antibodies. He does not own those antibodies. Somebody or something else produced the antibodies. And since the acquisition of antibody does not follow a natural mean or is not because of a natural mean, it was introduced through a syringe, then you will classify that one as artificial form of immunity. So putting them together, this is an example of artificial passive immunity. So administration of tetanus toxoid induces artificial active immunity, while administration of tetanus immunoglobulin is an example of artificial passive immunity. Hep B vaccination is an example of artificial active immunity. Very good. And then COVID-19 survivors donating plasma to patients with severe COVID-19 infection. This is an example of still artificial passive immunity. Some of you would think, the antibodies were naturally produced by the survivors of COVID-19. Why is this not classified as natural passive? Again, the transfer of antibody does not follow a natural mean, right? The antibodies were removed from the donor and were introduced through the vein of the patient or the patient with the severe COVID-19 infection. You will never understand the different immune responses if you will not be reviewed on the different types of white blood cells. Anyways, they are the main key cell players in the immune responses. You have learned from your anatomy and even in histology that there are 5 types of white blood cells, and they are classified as 2 whether they have granules in their cytoplasm or not. Those that contain granules are classified as granulocytes, and you have 3 members: BEN, basophils, eosinophils, and neutrophils. Those that do not contain granules in their cytoplasm are referred to as agranulocytes, and you have 2 members. And it's easy to memorize their name because both of them would end with cytes: monocytes and lymphocytes. The 3 granulocytes are neutrophil, eosinophil, and basophil. Please recall that the most commonly used staining method in histology laboratory is H&E staining. Take a look at the picture of basophil. Can you appreciate that it has blue or dark blue colored granules in its cytoplasm? It means that it was stained with hematoxylin, and hematoxylin is a basic or alkaline dye. And since the granules of this cell have affinity to basic dyes, so therefore the cell was later named as basophil. Take a look at the granules of eosinophils. Can you appreciate that they are pink to red in color? And that's basically the color of eosine. So that's why this cell is named eosinophil. The granules of neutrophils have no affinity to both hematoxylin and eosine, and they usually have that lilac pink color. Since they are neutral to both hematoxylin and eosine, the cell was later referred to as neutrophil. Let us first start with neutrophils. Take a look at the picture of the neutrophil in the PowerPoint slide. Can you appreciate that it has lilac pink granules? Focus on its nucleus. Unlike with other cells in the body, which have round-shaped nucleus, the nucleus of neutrophils is lobulated, and the lobes can range from 3 to 5. Since the nucleus of a neutrophil is lobulated, this cell is also known as segmenter because the nucleus is somehow segmented. And since the nucleus of neutrophil can have 3 or 4 or 5 lobes, these cells are also referred to as polymorphonuclears. Poly, many, morpho, appearance of nucleus. Many appearance of nucleus. Because sometimes it can have 3 lobes, sometimes it can have 4 lobes, sometimes it can have 5 lobes. So the other names for neutrophils are segmenters or polymorphonuclear leukocytes. Please take note that neutrophils are the most abundant white blood cell in the circulation. Neutrophils comprised 55 to 70% of the total white blood cells in the circulation. So if you are performing differential count in the blood smear of a healthy individual, expect that after counting 100 white blood cells, 70% of them could be neutrophils. Neutrophils are classified as granulocytes because they have these granules in their cytoplasm, and they usually have lilac pink color. These granules are known to contain powerful digestive enzymes. That's why neutrophils are really good in digesting any engulfed material. Neutrophils are the first cell to reach the site of infection. So they are the first white blood cell to go out of the blood vessel and go to the site of injury or infection or inflammation. Now, there are 2 reasons why neutrophils are the first one to reach the site of infection. Number 1, they are the most abundant. Number 2, they are the most sensitive to chemotactic factors. Chemotactic factors are chemicals released by microorganisms. So if these chemotactic factors will reach the blood, the first cell to detect these chemotactic factors is the neutrophil. Neutrophils are good in phagocytosis, And the organism that is commonly killed in phagocytosis is bacterium. That's why if a person would have neutrophilia, meaning neutrophil count beyond 70%, that would only suggest that the person is having an infection and the infection is of bacterial type. Since neutrophils contain enzymes in their granules plus the fact that they have lysosomes, so that makes them good in digesting any phagocytosed or engulfed material. The problem with neutrophils is, so take a look at the picture of the neutrophil in the PowerPoint slide. Can you see that this neutrophil is currently engulfing foreign materials? The problem with these neutrophils is that as they form the vacuole during the phagocytosis, they can't help but allow some of the enzymes in their cytoplasm or granules to escape. One of the enzymes that will leak out is elastase. Good thing about the leakage of this enzyme is that these enzymes can target those bacteria that were not yet eaten by the neutrophils, and that's a good effect. The problem is the elastase enzyme can also destroy the tissue with the infection. So, neutrophils are double sword. They can protect you at some point, but they can also cause damages to our tissues. But don't worry about the leakage of elastase because every time that we're having acute infection, expect that neutrophils will migrate towards the site of infection and the liver will produce a protein that we call as alpha-1 antitrypsin. So take a look at the picture of the neutrophil on the left side of the screen. Can you appreciate that it has released the elastase enzyme during the process of phagocytosis? There's that protein that is colored pink in the picture. That protein now is alpha-1 antitrypsin, and its main role is to not allow the leaked elastase to cause tissue damage. So expect that people born with alpha-1 antitrypsin deficiency to have tissue damages secondary to bacterial infections. Why? Because every time that this bacteria will be engulfed by the neutrophil, there will be subsequent release of elastase, and the elastase will destroy the tissue where the bacteria are found. That's why people with alpha-1 antitrypsin deficiency will have problems in their lungs. Every time the neutrophils will try to clear off the infection there, they will also cause damages to the lungs. Liver can also be involved. This schematic diagram is showing us that the first cell that will emerge out from the blood vessel in the process called chemotaxis and will reach the site of infection is our neutrophil or segmenter or polymorphonuclear leukocytes. 1 to 2 days after the neutrophils were recruited from the blood into the site of infection or injury, these neutrophils will program themselves to apoptosis. So they will eventually die and become the pus. Take note, the pus is an accumulation of dead white blood cells. So you can have their dead monocytes, but the main component is dead neutrophils. So if neutrophils would die 1 to 2 days after they were recruited from the blood vessel towards the site of infection, there must be another cell that will replace these neutrophils. And what do you think is the cell? We will discuss that later on. Again, 1 to 2 days after the recruitment from the blood vessels towards the site of injury, neutrophils will undergo apoptosis and they will produce what we call the pus. I have 2 questions. Which among these types of neutrophils undergo apoptosis 1 to 2 days after their migration towards the site of infection? They must be replaced by another cell that is also good in phagocytosis to continue the battle. And the cell that will replace the neutrophil is the monocyte. So take a look at the picture in the center. Can you appreciate that the first cell that will emerge out of the blood vessel is the neutrophil? And then the picture in the middle will also show you that after the neutrophil, the monocytes will follow. So the second cell to reach the site of infection is the monocyte. The second granulocyte that we will discuss is eosinophil. As you can see in the picture, eosinophils have bilobed nuclei. And as mentioned a while ago, they are named eosinophils because their granules have affinity to the eosin dye. If the granules of neutrophils contain digestive enzymes, the granules of eosinophils primarily contain major basic protein. Major basic protein, and this chemical can be damaging to parasites, especially the adult and larval stages. So expect that the count of eosinophil will go high if the person has parasitism. So how do you think eosinophils will generate immune responses against parasites? So take a look at the eosinophil pointed by the red arrow. And then this is most likely the tail of the worm that it's supposed to attack. Appreciate that the parasites are too big for the eosinophil to phagocytose. Take a look at the antibodies coating the surface antigens of the parasite. And since the eosinophils cannot do phagocytosis on parasitic worms, the eosinophils will just simply bind to the tail portion of the antibodies, and the binding of the eosinophil to the antibodies will cause the eosinophil to degranulate and release the main content of its granules, which is what? Major basic protein. And this immune response is called ADCC. ADCC stands for antibody dependent cell cytotoxicity, because in the immune response, the eosinophil became toxic to the parasite because of its binding to the antibody. The entire process was initiated by the binding of eosinophil to the antibody. That's why this one is referred to as antibody-dependent cell cytotoxicity. So take a look at the parasitic trematode or fluke in the picture. It's very obvious because it's dorso-ventrally flattened, it is lancet in shape, and it is unsegmented. Please appreciate the presence of numerous eosinophils around it. These eosinophils are attacking this parasitic fluke. And most likely, these eosinophils are bound to the antibodies that are binding to the surface antigen of this parasitic fluke. The degranulation of eosinophils in ADCC, or antibody-dependent cell cytotoxicity, results from the binding of the eosinophils to the antibodies that are bound to the surface antigens of the parasite. So take a look at this parasite and see how the eosinophils attack it after discovering the presence of antibodies on its surface. The third granulocyte is the basophil. It's named such because its granules are stained dark blue when they take up a basic dye. Take note, just like in the case of eosinophil, basophils also have bilobed nuclei. But most of the time, the nuclei of basophils are difficult to distinguish or identify because they are obscured by the presence of the dark blue granules. Now, if you have enzymes in the granules of neutrophils, major basic protein in the granules of eosinophil, what is now the primary content of the granules of basophils? The main content is histamine. And you know very well that histamine is a chemical mediator of common allergies. So this cell is most likely involved in the pathophysiology and pathogenesis of the common allergies we know. There's one cell that is always linked to basophil, and that's the mast cell. The very reason why the mast cell is linked to basophil is that it also has granules that contain histamine. And it is also known that these mast cells can also induce common allergies. One difference is that you can only find basophils in the blood, but mast cells are found in the tissues. Before, they were saying that mast cells are derived from basophil. So every time the basophil will migrate from the blood vessel to the tissue, it will differentiate to form the mast cell. Today, studies have shown that basophils and mast cells are completely different cells because they are derived from different precursors in the bone marrow. So what is now the difference between basophil and mast cell? Basophils leave the bone marrow already mature and it will just remain circulating in the blood. While mast cells, on the other hand, will leave the bone marrow immature and will only reach maturity once it will migrate and reside in the tissues. Basophils and mast cells may have the same components in their granules, but they are two different types of cells. Basophils are found in the blood, while mast cells are found in the tissue. Take note, both of them are involved in the pathophysiology and pathogenesis of common allergies. So let's discuss the pathophysiology of common allergies. You have here the introduction of the allergen into our body. So let's say, for example, the allergen entered through the respiratory tract. The allergen will enter through the epithelium, and according to the picture, the allergen will be captured, sampled by the antigen presenting cell. In the picture, you have there a dendritic cell. I want you all to appreciate that this dendritic cell will get a portion of that allergen, and that portion of the allergen will be presented to a T helper cell. So I want you to imagine the dendritic cell will phagocytose the whole allergen, and it will choose a certain portion of the allergen, and that portion of the allergen will be presented on its surface, and that portion of the allergen will be presented to T helper cell. The activated T helper cell will activate B cells. And if activated, these B cells will become plasma cells. And plasma cells will generate the blue-colored antibodies in the schematic diagram. These antibodies are IgEs. IgE. Do you know the unique property of IgE? So take a look at the yellow rectangle. The IgEs produced in response to the presence of the allergen will all display themselves on the surface of mast cell or basophil. Can you appreciate that the blue-colored Y-shaped antibodies are displayed in the surface of the mast cell in the schematic diagram? Again, the T helper cell will activate B cells. B cells will become plasma cells. The plasma cells will produce IgEs, the yellow-colored Y-shaped structures in there. And then these IgEs will display themselves on the surface of the mast cell or basophils. Now, the IgEs will bind themselves on the surface of the mast cell via their tail portion. The tail portion is named Fc portion. Again, F, capital letter F, and small letter C. So I will spell the Fc portion in the PowerPoint slide so that it would be easy for you to write it down on your notes. So if I will ask you in the exam, which of the following antibodies has Fc receptors on the surface of mast cells, you should choose IgE. Take a look at the mast cell in the photo. Appreciate the presence of the vacuoles containing the histamine molecule in the cytoplasm of that cell. I want everybody to understand that histamine is not just randomly released from the vacuoles inside the cytoplasm of the mast cell. There must be what we call cross-linking first before the histamine molecules are released from the mast cell. So what do I mean by cross-linking? Take a look at the red rectangle in the photo. Cross-linking would mean one allergen should be able to bind to two IgEs at the same time, meaning two IgE antibodies are cross-linked by one allergen. The requirement for the release of histamine is for one allergen to cross-link two IgEs. Why do you think this one is important to take note of? Take a look at this picture. You know very well that what happens during the first exposure is that the allergen will enter the body. The allergen will be sampled by the antigen presenting cell, the cell that is color brown in the photo. This antigen presenting cell will present the allergen to the T helper cell, the blue colored cell in the picture. The T helper cell will activate B cell to become plasma cells, and the plasma cells will produce the brown colored Y-shaped IgE antibodies. Take note that the newly formed IgE antibodies will bind to the Fc receptors present on the surface of the mast cell or basophil. I want everybody to understand that there's still no cross-linking on the first exposure to the allergen, because cross-linking would mean one allergen cross-linking two IgE antibodies. This is basically the reason why you will wonder now, when you were younger, you are not reacting to dust particles. But how come today, every time you will try to clean your room and you will be exposed to even small amount of dust particles, you will automatically develop allergic rhinitis? Because when you were younger, you were just accumulating the IgE antibodies on the surface of your mast cells. And the number of the IgEs on the surface of your mast cell is not yet enough for cross-linking to happen. So I tried my best to come up with this illustration so that I can best explain to you what is happening during the first exposure to the allergen. So you have there a mast cell, and then in the cytoplasm you can see there the vacuoles containing the preformed histamine molecules. Then you have there the red colored IgE antibodies. What will happen during the first exposure is that these IgEs will bind to the Fc receptors present on the surface of the mast cell. And as you can see, there is no release of histamine from the mast cell because there's still no cross-linking. If you will be exposed again to the same allergen, the allergen will bind to one or two of the IgEs on the surface of the mast cell. But as you can see, that can still not cause what we call cross-linking. So in this case, the mast cell will still not degranulate. But after several more re-exposures, the number of IgE antibodies on the surface of mast cell will increase. That's the characteristic of adaptive immunity. The more that you're exposed, the higher the magnitude of immune responses. So what will happen? There will come a time that if you are exposed again to the same type of allergen, one allergen now can cross-link two IgEs because the IgEs are already crowding on the surface of the mast cell. And what will happen is that will now trigger the fusion of the vacuoles containing the histamine to the membrane of the mast cell, causing now the histamine to be released. So, after several re-exposures, there would be what we call cross-linking, and the cross-linking will trigger now degranulation or the release of histamine from the cytoplasm of mast cells or basophils. Again, the cross-linking of one allergen to two IgEs on the surface of the mast cell will trigger its degranulation. And what will be released is histamine. And histamine will act on different cells or tissues in the body that have receptors to it. First, it can act on smooth muscles of the respiratory passage. And what will happen? these smooth muscles will undergo contraction. So if the smooth muscles in the airway will contract, they will narrow now the airway passages, causing difficulty of breathing as shown in people with asthma attacks. Next, this histamine will act on the smooth muscles of blood vessels. And do you know the effect of histamine to the smooth muscles in the blood vessel? They will cause the smooth muscles to relax. So it's completely different from the smooth muscles in the respiratory tract. Smooth muscles in the airway passages will contract. Smooth muscles in the blood vessel will relax. So what will happen? The blood vessel now will dilate. And with vasodilation, the blood pressure will go down. Why? Because you have there a lumen of the blood vessel that is already dilated. So the blood flow will slow down, and that will have a consequence to the blood pressure. So people with massive histamine released from mast cell will have vasodilation, and there's a chance that they will develop hypotension. Next, this histamine will also act on mucous glands, increasing their secretions. That's why people with allergic rhinitis, okay, will have frequent watery secretions coming out of their nasal passages. It's because of the increased mucous secretion brought about by the effect of histamine. Histamine will also act on sensory nerve endings, inducing now pruritus or itchiness. Histamine will act on the smooth muscle cells of the respiratory passage, resulting to bronchoconstriction. Histamine will act on the smooth muscles of the blood vessels, causing now vasodilation. Plus, I want you to listen very carefully, it can also increase vascular permeability, meaning it will allow some of the fluids in the blood to leak out of the blood vessel. I want you to imagine the vasodilation has already caused drop in blood pressure. If you allow some of the fluids to leak out, and that would cause decrease in the blood volume, that will worsen now the hypotension. And with hypotension, the organs in the body will receive less blood supply, and you call it as a state of shock. Histamine can also act on mucous glands, increasing their secretion, as shown in people with allergic rhinitis. And the pruritus is brought about by the action of histamine to the sensory nerve endings. At this point, let's discuss the other physiologic effects of histamine. So, shown in the picture, you have their bronchoconstriction. We have already discussed about that. Next, do you know that our intestinal tract has receptors to histamine? And histamine, once they will act on the receptors in the intestine, they will increase the rate of peristalsis. If the peristaltic activity is increased and there's no time for food to be digested, the undigested food now will cause irritation in the intestinal lumen, and the only way for the intestine to get rid of the irritation is to dilute the undigested material. And how do you think the intestine will do that? By drawing in water into the lumen, and that will now result to diarrhea. That's why some people who have allergies will manifest with diarrhea. So next to it, you have their vasodilation and increased vascular permeability, possibly leading to hypotension and later shock, which is life-threatening. Do you know that there is that one particular cell in the stomach, we call it as enterochromaffin-like cell, and it activates the parietal cells to produce hydrochloric acid. How do you think the enterochromaffin-like cells will activate the parietal cells to produce hydrochloric acid? These ECL or enterochromaffin-like cells are capable of producing histamine, and histamine now will act on parietal cells, causing now the production of HCl. So if you have allergies and you have release of histamine from your mast cells or basophil, the histamine will act on the parietal cells, causing them to produce high amounts of hydrochloric acid. That's why some people with allergic reactions will present with epigastric pain because of the increase in the production of hydrochloric acid in the stomach. So, the summary is, first exposure to the allergen will just result to the binding of the IgEs produced to the Fc receptors present on the mast cell and basophil. There is no degranulation at this point. But after several re-exposures, cross-linking will happen, and that will now result to the release of histamine from the cytoplasm of the mast cells and basophils. And histamine now will cause the different physiologic effects or clinical manifestations. I hope you will memorize these discussions by heart, because once we will go to the hypersensitivity reaction, this concept will be discussed again. Let's have a case. So let's say a boy was stung by a wasp or a bee. The boy was then rushed to the ER because after complaining of severe pruritus, the boy lost consciousness. In the ER, it was found out that the kid's blood pressure is very low. What do you think is the reason behind the hypotension of the child? Bee sting can cause anaphylactic shock. And when you say anaphylactic shock, this is caused by release of histamine from the mast cells and basophils, causing now vasodilation and increased vascular permeability, leading to the drop in the blood pressure in the body of the individual, resulting now to decreased blood supply to the organs, and that is now what we call the state of shock. My next question is, why do you think bee sting can cause anaphylactic shock when in fact, according to our discussion, you must be exposed first to the allergen before you will have the accumulation of IgEs on the surface of mast cells before cross-linking can happen. In the case of this patient, the patient was only stung once by the bee. The thing is, you don't have to be stung by the bee for several times before you will develop anaphylactic shock. So what is now the probable reason why patients who were stung by bee would develop anaphylactic shock? I hope you will listen to my discussion. Do you know that some of the allergens present in other food that can trigger allergies, yung crabs, other crustaceans, shrimps, the allergens found in them could be also found in the bee sting. So when the child was stung by the bee, the allergen introduced through the bee sting was mistaken by the IgEs on the surface of mast cell or basophils as the crab's allergen or the crustacean's allergen. And it still led to the degranulation of the mast cells and basophils. And that is now what we call cross-reactivity. Antibody to antigen A also reacted to antigen B because antigen A and antigen B shares some similar structures or parts. What I want you to understand from this picture, after the cross-linking of one allergen and two IgEs, the histamine will be released. But I hope you understand that the mast cells are preformed, meaning you only have limited amount of histamine in the cytoplasm of the mast cells. So if that's the case, the allergic reaction should go away minutes or hours after. But how come in people with asthma or people with allergic rhinitis, the attack can last for a day or two? So there must be a chemical that will sustain the allergic reaction, and that chemical is no longer histamine. So what is that chemical? Let's have a review first of the components of the cell membrane. The most abundant component of the cell membrane is the phospholipid, the one that is highlighted in the picture. The phospholipid contains a phosphate head, the blue circle, and it has two fatty acid tails. One of the fatty acids is arachidonic acid. Later on in the course of the allergic reaction, the arachidonic acid fatty acid tail of the phospholipids of the cell membrane of mast cell will be cleaved and will be released into the cytoplasm. The released arachidonic acids will be acted upon by lipooxygenase enzyme. And this enzyme will convert the arachidonic acid to leukotrienes. There are a lot of leukotrienes, but I would like to highlight three of them: leukotriene C4, D4, and E4. And take a look at their physiologic effects. You have their bronchoconstriction, you have their increased vascular permeability, you have their vasodilation. So, these are the chemicals now that will mediate the allergic reaction on the later part of the condition, especially if the histamine, preformed histamine molecules were already consumed. Since they act a little late compared to histamine, these leukotriene C4, D4, E4 are referred to as the slow reacting substance of anaphylaxis, SRSA. SRSA, slow reacting substance of anaphylaxis. That's why if you have a patient who has allergic reactions and they are no longer responding to antihistamine, that's the time you should entertain the possibility that the allergic reactions or the manifestations are no longer caused by histamine, but they are already mediated by the slow reactive substances of anaphylaxis, your leukotriene C4, D4, and E4. In managing common allergies, we usually prescribe to the patient cetirizine or levocetirizine or loratadine. And take note, these are histamine 1 receptor antagonists, meaning they will not allow histamine to bind to its receptors. That's why it cannot anymore mediate or cause the physiologic effects. So that's why the patient will feel relieved of the allergic signs and symptoms. Now, in cases wherein the manifestations are no longer because of histamine, but they are because of the slow reactive substances of anaphylaxis, we can also give certain medications. So I want you to take a look at the arachidonic acid in the picture. As you can see, it's supposed to be acted by 5-lipoxygenase. You can actually inhibit that enzyme so that there will be no production of leukotriene C4, D4, and E4. And the drug that you can give is Zilioton. You can also give what we call the Montelukast. I know you're already familiar with this. Montelukast is actually leukotriene C4, D4, E4 receptors blocker. So it does not allow the leukotrienes C4, D4, E4 to bind to the receptors and cause the corresponding physiologic effects. So if you know someone who has asthma and that person is taking Montelukast plus levocetirizine, it's popularly known as Zicas, you can actually sit down with them and tell them, do you know that the levocetirizine is H1 blocker? It will not allow the histamine to cause the manifestations of the allergic reactions. And you also have there the Montelukast, which will block the receptor for leukotriene C4, D4, and E4. The person sitting beside you will most likely be amazed of you because you know those things. And that ends my discussion to Introduction to Immunology Part 1. Thank you for listening. Will provide immediate protection. Is it the active or the passive? The answer is passive immunity because you already have prepared antibodies which can immediately protect the person. Because active immunity would require time before the person will be able to produce the antibodies. Next question. Which among the two will provide lifelong immunity? The antibodies introduced through passive means will eventually run out, will eventually become consumed. But the antibodies that you produce through active means will be again produced in higher amount the moment that you will be re-exposed because you will develop memory cells. And that's the basic concept of adaptive immunity. So what will protect you for lifetime is the active immunity. But what will provide immune response immediately is the passive type of immunity. Immunity can also be classified as active or passive immunity. When you say active immunity, you produced the immune response after you had the infection or after you were vaccinated. But when you say passive immunity, somebody produced the immune response for you. That's why the passive immunity is defined in the schematic diagram as immunity or immune responses you acquire from someone or something else.